Okay. No problem. The more the merrier. Okay. Hi guys, good evening and welcome to our medication management lecture. Today we will be talking about four major things. First thing is high alert medication, look-alike and sound-alike medication, and reporting of medication errors, um, how to prepare medications, and adverse drug reaction reporting, and of course, restricted antibiotics. So first thing first, the first three things we're talking about, our first three topics are ESR topics. ESR topics means that they are essential safety requirement topics that we have to know, we have to pass, and everyone needs to know how to deal with them. First thing, first, before I start, I need to tell you something. Please concentrate here and concentrate with us because by next week we will be giving you, Sibahi is due maybe in the first 2 weeks of February, okay? And by next week we will be introducing these cards. These cards are frequently asked questions by the Sibahi surveyors. You will have the cards with you, read them, learn them, know how to answer the surveyors. Okay, first thing we're talking about in the medication part is the management of high alert medication. What are high alert medications? They are medications that bear high risk of causing significant patient harm when they are used in error. It does not mean that errors occur with these medications more than any other medication, not at all, but when something wrong happens with these medications, the harm is significant to the patient. Reducing harm with high alert medication is third international patient safety goal. Okay? What are examples of high alert medication, guys? What are examples that we know we deal with every day for high alert medications? No, I need answers. I know it's the end of the day and everyone is tired. This is my second time repeating this. So tell me, give me answers, give me examples. High alert medication. Narcotics, adrenaline, concentrated electrolytes, insulin. We use insulin every day. Insulin is a very high alert medication. Warfarin is a high alert medication. Okay? So, examples are narcotic, concentrated electrolytes, insulin, adrenergic agonist, adrenergic antagonist, anesthetic agents for those who work with anesthesia, antiarrhythmic. The latest addition to the high alert medication list is tranexamic acid. What is tranexamic acid? Cyclopaprin. This list, where do you find this list? Everywhere. This list is available in all places where medications are prepared, administered, or prescribed. So this high alert list is in all the stations, it's in the medication room, it's in the pharmacy, they are in the clinics, it's everywhere. Where does this list come from? Pharmacy. How annually is how soon is this list updated? Annually. So every year we have a new list for this. Okay? What are the steps that we take in this hospital to reduce error when it comes to high alert medications? I know that you all know, so let's take it one by one. Someone from here tells me only one. Maya, tell me how we do that. Red bins. We put red bins. What else we do? Labels. Okay. What about the quantity? Very little quantity. We reduce the quantity. Okay. So when we store them anywhere in this hospital where the high alert medications are stored, they are stored in very limited quantities and separated from the regular stock. So if you have your regular stocks in blue bins, these are separated in red bins aside, labeled with high alert labels. Okay? When it comes to concentrated electrolytes and neuromuscle blocking agents, where do we find it? Do we find it everywhere? No. In special care areas. Again, with very limited quantities. Special areas are like anything that has an R with it. OR, DR, NICO, anything that goes like that. Okay? Labor and delivery room, cath lab. crash carts, and then again, very limited quantities. They are not available as floor stocks. Concentrated electrolytes are not allowed to be kept as floor stocks, only in your crash cart. Or if you're a special care unit, then you will find concentrated electrolytes there. When it comes to prescribing high alert medications, these medications should be prescribed clearly, okay? They should have a very clear prescription. For example, potassium chloride injection, 10 millimole. This is the concentration. KCl in 500 ml of normal saline, 0.9, with the exact rate that we need to give for the patient. Okay, so KCl, just BID, is not allowed. Okay? Verbal and telephone orders when it comes to high alert medications are limited to urgent or emergency situations. What happens when we get a telephone order for high alert medication? What do you do? What's your policy when it comes to telephone order or verbal orders? Yes, it's the regular policy. It's nothing special. So what do we do? And read back. Okay. Okay. Again. So medications are prepared in the pharmacy. Medications are prepared in? Bravo. Good life. Okay? So medications are prepared in the pharmacy. And in urgent or emergency situations, medications are prepared in the medication room by qualified nurses under aseptic techniques. Okay? Do we all know the aseptic techniques? How do we prepare medication, hand hygiene, do everything, and clear the surface, isopropyl alcohol, from right to the left, from in to out, and yes, okay? One important thing when it comes to high alert medication is independent double checking. What does independent double checking mean? Check it independently, separately from each other. Okay, so one, yes, individually. One checks, leaves the place, someone else can come and checks again. Okay, what is the proof of the independent double check? 2 signatures. Okay, so for administration, you receive the medicine from the pharmacy, and now you're going to administer it to the patient. Before administration, when you receive it from us, you need to double check the name, the concentration, and the medication, okay, from the pharmacy. And then you go to your station. What do? Double check what you received from us against the doctor's order, okay? So you receive the high alert medication from us. For example, insulin, Novomix, saying Novomix 20 international units BRD, okay? You receive that, it says that on the label, everything is okay. You go back to your station, double check it against the doctor's order. If it's actually Novomix, if this is what the doctor prescribed, if the dose is right, if the route of administration is right, and the rate is right. And then, here where it comes independent double checking. 2 nurses will independently double check the medication, okay? After that, they will put what? Affix their signatures in the medication document, okay? Again, this is a very important question. You need to be very well aware of the independent double check process, okay? Because they would come in and ask you directly, what is an independent double check? Independent double check, 2 people separately checking and comparing their results, okay? And then, when you independently double check, how many identifiers do you use for the patient? What are the 2 identifiers you use for the patient? And full name. 3 names, okay? Is the patient room number or the patient bed a proper identification? No. Okay. Another method of reducing errors with high alert medication is using concentrated electrolytes. In this hospital, we use, standard concentration. In this hospital, we use standard concentrations for our medication. For example, we have only 1 concentration for the magnesium in the entire hospital. You will find the same concentration in the inpatient, outpatient, or anywhere where magnesium is used. Sodium, the same. all concentrated electrolytes or medications with high alert medication who has different, that comes like from different companies with different concentrations, we only have one concentration for that. Okay? When you prepare, in the case of emergency or urgent situation, you are preparing medications inside the medication room. What do you use? What's your reference? The manuals. Okay? Again, this manual is only found in NICO only. These are the two manuals that you will find anywhere else in this hospital. How to use the manual, because they will give you the manual and they will ask you to show them how to use it. How to use the manual. The manual is arranged alphabetically. So all the medications are arranged there, stated there in generic names alphabetically. Okay? And high alert medications are highlighted in yellow and written in red. So you would know, if you're preparing a high alert medication, that this is the medication you're preparing. Double check, take care, concentrate. Okay? Again, when it comes to labels, we know that the high alert medication has the usual red label. The usual red label says what? High alert medication, double check. Where is the label used? Where is it attached? On every ampule. It's attached individually on every ampule. Okay? And if it's like a Clexane injection or an injection, it's there on the injection. Again, for concentrated electrolytes, you have a second label with the regular label that says it must be diluted. For neuromuscular blocking agents, usually it will have this label, but the neuromuscular agents are not available everywhere in the hospital, so you will not be seeing this label a lot. If it's there, it's going to have this label on the pouch, because the ampules will not be enough to take the labels, all the labels. And then if you put all the labels on the ampules, you will not know what this ampule is. Okay? So let's have a quick recap. How do we deal with high alert medications in this hospital? What are the steps to reduce errors with them? Limit stocks, storage. Yes. Separate them, yes, from other medications. No, that's for the LASA. Okay. Independent double checking. Okay. LASA medications. What are LASA medications? Look-alike and sound-alike medications. These are medications that either look alike because they have similar packaging, or sound alike because they have similar phonetics. Okay? Or when they write them, they look alike. Like ceftriaxone, ceftazidime. They write them and they look alike. This is the list of look-alike and sound-alike medications. What are the colors of the look-alike and sound-alike medications? Orange and green. Okay, orange is for the sound-alike. So there's a label that says, in your crash carts, if you look at the crash carts, and look-alike and sound-alike medications would have a label there. One is orange and the other one is green. Okay? This is the list. Where does the list come from? The pharmacy. The list is provided by the pharmacy. This list is annually updated, as well as the high alert medication list. Okay? Again, this is an example. This is magnesium and this is potassium, by the way. These are two different medications that they look alike due to their packaging. Okay, the list is available everywhere. The list is written in Tallman lettering. Okay? When we're storing look-alike and sound-alike medications, what do we do? What are the steps we take upon storage? Non-alphabetical, Tallman lettering, and the labels. The labels that says, yes, green and orange. Okay? So, 3 steps when storaging. The labeling is green and orange. They are stored in a non-alphabetical manner, and we have a Tallman lettering on the labels. Yeah, the auxiliary labels that said look alike and sound alike. Okay, when you're prescribing, when you're getting a prescription for a Lassa medication, the prescription should have medications for Lassa medication should be prescribed in generic names, not in brand names. Even if the brand name is written there, a generic name should accompany the brand name because this will help you distinguish between them. Okay? This is one thing. The second thing, diagnosis should always be stated in the prescriptions for the Lassa medication because medicines such as Ezipan and Ezilax, these are two medications, these are Lassa medication, but each of them is used for something differently. Ezilax is a laxative, Ezipan is a cough syrup. So if it says constipation and it's prescribed Ezipan, we know something is wrong. Okay? So always have a diagnosis, always have a generic name with the brand name, but generic should be the thing that you use. Again, verbal and telephone orders for Lassa are reduced to minimum. Verbal and telephone orders for Lassa should only be used in emergency or urgent situations like high alert medications. Again, when taking a verbal order or a telephone order for a Lassa medication, communicate clearly the full order, generic and brand name, spell out the drug name, and indication and dosage whenever a verbal order or a telephone order is taken, and ask the recipient to repeat what you're saying. Okay? Administration. Okay, you got a Lassa medication and now you're going to give it to the patient. What do you do? Double check. Double check what you received against the doctor's order. Double check the medication that you received against the medication label, because maybe we gave you the wrong medication. The label is right, but we gave you the wrong medication. Okay? When receiving a phone or verbal order, read back and double check. Independent double check is always, I'm sorry? Exactly. Write down everything. Confirmation and independent double check. Independent double check is the keyword for everything when it comes to high alert medication and Lassa medication. Okay? Again, they would ask you always, they'd always like bring out the list of look-alike and sound-alike medication and ask you, why are the medicine written like this? Why are they written like that? To reduce errors. What is this? Tall man lettering. Okay? Reporting medication errors. Hi. Hello. How many of you have reported medication errors? Silence. Everyone goes silent. Okay, guys, reporting medication errors. Why do you think people in this hospital do not report medication errors? Why do you think you don't report medication errors? Because they're afraid, right? Okay, so have you ever heard of anyone in this hospital being punished for reporting medication error? No. So why are you afraid? No, we actually have some medication errors and they're really good, by the way. But the thing is, why are you afraid of reporting medication errors? You know who will know that you reported medication error? Only the pharmacy. Only the pharmacy. Your doctor will not know that you reported a medication error. So if people are afraid because they have to work with these people again, like I totally understand that some people do not want to report because they are afraid that they have to go back and work with the person that they have reported. No, they will not know. Only the pharmacy knows. And the pharmacy really doesn't care if you report the doctors or not. We actually find it something nice. We find it as a satisfying thing. So we don't mind that you report your doctors or you report us, because sometimes we are the one who do the errors. Sometimes we give you wrong medications. So that's a medication error. You need to report that. Yeah, the thing is, we don't mind, again, yes, but the thing, you would inform us, but you would not write it down. That's the problem. You will call us to check, okay, you gave me this wrong medication and I want this because this is the right one for the patient. But you will not put it in writing. We don't mind you putting it, right? Neither me as a pharmacist nor you as a nurse will be punished. What will happen is, we will take these medication errors, we will know what happened, why did the error happen, and try to reduce the error. Try to prevent it from happening again. Because this time, I gave you a wrong medication, and you did not give it to the patient because you noticed. So it's a near miss. It did not reach the patient. But maybe next time, with like a lot of patients and a lot of hassle around the hospital, you will give it to the patient and then it will reach the patient. But if we know why it happened in the first place, we will stop it from happening again. Maybe we will implement another, like a system in the pharmacy to double check your orders again, okay? To double check before giving you the medication, to maybe come to you and ask you if something is wrong with the doctor's order that we see in front of us, ask you to give us the written order. So no one is getting punished. You know what? Even if it reaches the patient, no one is really getting punished. What happens is insurance takes it all. Insurance deals with it. So you think doctors do not make mistakes in surgeries all the time? Surgeries happen, injuries happen, and mistakes happen. But then we report it, we know it shouldn't happen again, we stop it from recurrency. Please feel safe to report medication errors. I know that you are understaffed. I know you're super stretched. I know you don't have time. I know sometimes it's a long process in reporting medication errors and writing the paper, pinning it, and it might seem like it's not understandable. It's hard and I cannot fill it. Okay? If you feel it's hard, come to me. I will help you with filling your medication error. But please report. The thing is, we need to know what's happening at your station. Don't be afraid. Okay, so just tell us. Tell us we have a medication error. Something happened. Okay, something went wrong. It did not reach the patient, but it happened. Then we will take care. Maybe we'll provide you. You know what? Last year we had a bunch of medication error regarding inpatient inpatient inputting medications on the system. Tobrex and Tobradex were usually confused together in the system. I know it's not fully implanted, but we had a memo after a while, after checking out why are the medications written wrong on the system. We figured out that sometimes the nurses are really in a hurry, they have a lot of patients, and they're typing the medicine, the list come down, and they choose the first medication they see. Okay? It's not your job to enter the medication on the system. Okay? So we have a memo. We have a memo actually asking the resident doctors, they're the one who should be entering the medications on the system. We are trying to help you. If you don't tell us what's the problem, we will not be able to help. Okay? So, 4 important definitions you need to know. The definition of a medication error, the definition of a near miss, a hazardous situation, and a sentinel event. So, a medication error is any preventable event that may cause or lead to an inappropriate medication use or patient harm while the medication is in control of a healthcare practitioner. This is what happens every day. Something happens, we have the medicine, we try to give it to the patient, maybe it's the wrong patient. I have 2 patients taking the same medication, or a medication with a look-alike and a sound-like medication. I'm giving it to X patient rather than the other patient. I find in the last minute and it does not reach the patient. This is called a near miss. Okay? So, a near miss is an event that could have resulted in an unwanted consequence, but did not, because of, by chance or through timely intervention, the event did not reach the patient. A hazardous situation does not have to involve medication. A hazardous situation can involve anything. It's any condition that is likely to cause a death or a serious personal injury to person exposed to such conditions. Such conditions that do not involve medications are slippery floors, running through the aisles, running down the stairs, holding sharp objects and walking around. This is a hazardous situation. Okay? A sentinel event is any event leading to serious patient harm or death and is caused by a healthcare rather than the patient's underlying illness. So the patient comes in because she's giving birth. That's not an illness. She's gonna get some new baby to this world. And then by something happens and this patient dies. This is a sentinel event. Okay? Sentinel events should be reported. This is a very important thing. As far as I know, we don't have sentinel events in this hospital. Ma'am France, do we have any? No. Okay? So as far as I know, we don't have any sentinel events in this hospital, which is a good thing. Most of our events are near misses. People do not die in the hospital because of us. They die of other things, not for us. Anyway, types of medication errors. It starts with prescribing. So prescribing, transcribing, dispensing, administration, and monitoring. How do you report medication errors? So you find out a medication error. What do you do first? Patient safety comes first. Okay? If the medication error have reached the patient, stabilize the patient first, then report. Reporting does not come first. Patient safety comes first. Once identified, the medication error should be reported to the attending physician, the nurse supervisor, the pharmacy designee, or the supervisor within 1 hour. 1 hour to report to your supervisor. Not to the pharmacy, not to the quality, not to anyone. Pharmacy, to the supervisor, 1 hour. The doctor needs to know what happened to their patient if the medication error has reached the patient. Okay, again, 1 hour if the medication error have reached the patient. And then you have 24 to 48 hours to fill this form. Why 24 to 48 hours and why not more? We need the events to be fresh in your mind. Okay? We need you to remember everything. We need you to know. The only part of this form that you need to fill is the blue part. This part. Okay? This is the part that you need to fill. If you do not want to put your name, you are not obliged to put your name. Okay? But we need to know who are we giving our feedback to. Okay? That's the only thing that we need your name for. Because we will be providing you with a feedback, telling you what did your medication error help improve. So if you don't want to put your name, it's totally up to you. We'll be giving the feedback to the nursing director. But I would urge you to put your name anyway. No one is going to know that you reported. This is an anonymous file. This is an anonymous form. It's not a part of any patient record. And it's only for the pharmacy's eyes. Okay? Fill this form. This part of the form here is to describe the event. The event needs to be described in details and only by stating facts. No opinions, no nothing. Okay, just tell us this happened, this medication was entered on the system, the pharmacy gave the wrong medication, we received the wrong medication, we called the pharmacy and the pharmacy changed the medication. That's it, thank you. Okay? Just put the... And of course, again, the doctors needs to be notified. Okay? Only medication errors that have reached the patient will be documented in the patient file. Near misses do not go in the patient's file, okay? So only if the medication error reached the patient, like we gave the wrong medication to a patient, then we will write in the file. Where do you write in the file? Progress notes, okay? The feedback. So, inshallah, God willing, you give us a medication error. Okay. What will happen? What do you expect from us? You would expect from us a feedback. Feedback is in two mechanisms. First mechanism of feedback is direct feedback. So you give me the paper, we acknowledge that you reported a medication error, we thank you and everything. We thank you and we tell you that we're going to work on it. Okay. The second feedback is formal feedback. Within 10 days, you will be receiving supposedly an email, but since emails are not active or the servers are down most of the time, so we will be giving you a report, okay, a formal report of what happened. The content of the feedback we will review the details, we will tell you what we did for inspection, We will tell you what the identifying contributing factors happen. We will offer constructive feedback. We will try to help you if the medication error, like say, an omitted dose. We will be trying to give you ideas on how to overcome the workload, or working with others, like departments in this hospital, to help overcome that. So we will be giving you feedback on what did your medication error help us achieve. Okay? Again, always remember, in this hospital, medication errors are non-punitive. No one will blame you. No one will punish you for reporting a medication error. And they are anonymous. They are secret. No one will know them. We will have numbers for the medication errors. When we receive the forms, we put numbers on it. And that's how we deal with the medication errors. For us, they are numbers. No names, no nothing involved. Okay? Restricted antibiotic use. We have been seeing a rise in the use of restricted antibiotics in this hospital, mainly due to the influx of MOH patients coming to us, okay? So most of them are multi-drug resistant patients that they have to use a lot of restricted antibiotics. So we have 4 groups of the antibiotics are divided into 4 groups, A, B, C, and D. A is the general use medication. It's the general use antibiotics, the antibiotics with narrow spectrum. Okay, as we go down the groups, these are the widest spectrum antibiotics. And these are the ones that we keep on, like, this is like the Sapazifta, the Imipenem, and all of these medications. So, group A, anyone can prescribe them. Any doctor in this hospital can prescribe group A. Group B, it's a restricted, it needs a culture and sensitivity thing result to tell us why why are they prescribing these medications. But again, these 2 groups do not require a form. Okay? The form is only required for groups C and D. Those 2 groups should be only prescribed by specialists and countersigned by consultants. The consultant should sign the form within 24 hours. Okay? Please, people, do not coddle your doctors. Make them sign the papers. Make them sign the papers. Make them write the papers. Your only part in this, you need to fill this part. This part. The isolate or the pathogen. Okay? They need to write their medication order. They need to write this. This part needs to be written by the physician. They need to sign it. Signing medication orders are not hard. They're supposed to be coming in every day to check on their patients, right? So let them sign. On weekends, let them sign double. I'm not kidding. On weekends, make them sign 2 papers. If I know that this patient is still admitted tomorrow, make them sign another paper. Or there is an easier way for that. Write the duration. The duration should be mentioned. We have the medicine. It should be used. This is the antibiotic. This is the route of administration. This is the concentration, and this is the duration. If there's no duration, then we have to have a paper for each day. Okay? If the duration is written there, that's all we need. For empirical antibiotics, you have 3 days. If you choose here that it's an empirical use, you have 3 days of one form for each patient if you put the duration. Okay? If it's a regular antibiotic, the automatic stop order in this hospital for regular antibiotic is 7 days. So, if it's a regular antibiotic after a culture and sensitivity result, we can write here 7 days. So, you don't need to bother yourselves. This patient is still admitted tomorrow, and they will still take the same medication. Write a duration. Make them write the papers. بلاش دلع. Again, only this form is filled for C and D. Okay? A and B, you do not need to fill a form for. Okay? Now, this is the miscellaneous medication management topics I need to talk about. I'll try to be fast because, yes, already 8, almost 8. Pharmacy working hours, 24/7. Of course, Seriously? PR, we don't need your input here. Okay, when they come, emergency for the pharmacy is 24/7 because otherwise we will have to train you guys on how to come in the pharmacy and take the medication from the pharmacy. We don't need that. We don't need that, okay? So 24 hours. When it comes to multi-dose medications, what are the procedure when it comes to multi-dose medications? The label. Main thing is the label. Any multi-dose medication that is open, it should have the brown label for the multi-doses. Okay? The label has the date when it's open, the time, the expiry date as per the guidelines, not as per the expiry date written on the box. Okay? And the initial of the staff that first opened it. So I have Fusibact somewhere. It's open in the refrigerator or somewhere in station 5. They use a lot of Nebo. The ointment needs to have the labels. I need to see Yusra's initial on the label. I need to see the date of opening on the label. صح يا Yusra? Okay. Okay, on the Sibahi day, I don't want to see any multi-dose medications anyway. Yes, you will throw and get new. Okay? You will throw. If you have anything in the refrigerators, throw them away. Unless if it's insulin and we have to use it for a patient. Okay? This is the guideline. This is what we use to put the expiry dates on the labels. Okay, again, the expiry dates on the labels are not the expiry dates of the medication. It's as per the guidelines, what we call beyond use date. Okay? Where do we prepare medications? Come on. We've been lying all the time. So, where do you prepare medications? Yes, Helen. Except in emergency situations. Okay. When you receive the medication, a sterile medication from the pharmacy, what you have to do is, first thing first, you need to check the integrity of the medication. Okay? So if you're receiving a bag of medication, you have to double check for the particulates. There's no part. You have to make sure that there are no particulates in there. There is no sedimentation in there. That it's clear, and that the plastic bag is not leaking. So you need to squeeze a little bit to check that it's not leaking anywhere. Okay? And again, you need to check the content of this bag against the doctor's order. What is in this bag and what's in the doctor's order? Medications for inpatient. Patient's own medication. What happens if a patient comes in, is admitted, and they have their own medication? What should we do? Yes. Collect the medication and give it to a relative and ask them to take it home. Okay, so in the rare cases that the patient is using a one-of-a-kind medication that it's not only available, it's only available with the patient only. What do? We collect it from the patient and we fill a patient-owned medication form. And then what happens to this form? Where does it go? The form and the medications are given. Can we turn on the AC? I think they're gonna die. Everyone is okay. This form, along with the medications, are given to the pharmacy. ركز معايا يا اخي، انا عارفه ان انت مش تاخد patient ادويه من المرضى. So we will collect the medication that the doctor will say it's okay to use, only in the case that the medication is something that's not available in the hospital. Okay? We will take it from the patient, collect it properly, check for integrity, fill this form, and give the medication with the form to the pharmacy. Okay? Because in this hospital, the pharmacy should be controlling every single medication given to the patient. Okay? We cannot allow that we are staying outside and someone inside the room is using their own medication. Okay? Medications are not kept at bedside. Medications are only kept in medication rooms and in the pharmacy. Okay? I know this is something new, no one have heard of it, and usually everything is kept everywhere, but this is the proper thing to do. If the patient comes in with their own medication, collect it, give it to a relative, ask them to take it home. Fine? Because the doctor is anyway taking a proper history. So the doctor anyway knows the medication that this patient is using, and we will continue giving it from inside the hospital. In the rare cases that the patient is using a medication that it's not available in the pharmacy or does not have a therapeutic alternative in the hospital, we will take the medication from the patient, fill a patient-owned medication form, give the medication and the form to the pharmacy. Okay? They will be dispensing the medication after that. The drug information resources. Where do you get, if you need information about medications, how do you get it? Where do you get it from? We get it from the formulary, and we have the latest BNF on the system if you want to look at it. And again, the policies and procedures, this tells you how to deal with medications in this hospital. The formulary, this is our formulary. Have you seen this before? Alhamdulillah, people are saying yes. Yeah, I'm so happy. Okay, this formulary is available everywhere. It's available in the clinics, it's available in the stations, and it's available everywhere where medications are used. Okay, the formulary is also available online. To ease the access to it, go to the e-library, click on the icon for the e-library, go to the drug information resources, and you will find the formulary there. How to use the formulary. If they give you this book and ask you to, please check for me if you need information about adrenaline, how would you get information from here about adrenaline? How? Let me tell you. The end of this, we have an index at the end of this book. Okay? There's this index, and this index is arranged alphabetically. So what you're gonna do, go here, check for the medication, see the page number, turn to it, and that's it. Again, for ease of access, if you go to the online version, for both the formulary and the BNF, all you have to do is open the page, type up there in the search bar the medication name, enter, and you will be addressed to the page where the information is found. Okay? So the drug information resources are found in Elite Hospital Library or the formulary. Okay? This is the last thing. Reporting adverse drug reactions. What is the difference between a side effect and an adverse drug reaction? We anticipate side effects. We know side effects are going to happen. So for example, if you're taking an antihistamine, you would know that a side effect for taking the medication is being drowsy or wanting to sleep. An adverse drug effect is something unpleasant, that's unexpected. It's an unexpected surprise. You're taking a medicine, everything is perfectly okay, and then suddenly you cannot breathe. Okay, this is an adverse drug reaction. Who should report adverse drug reactions in this hospital? Everyone. Any clinical staff in this hospital who witnesses the adverse drug reaction. Anyone. Okay? The adverse drug reactions are usually reported by the first person who suspects it. So you see something, then you feel like the person is wheezing, the patient is wheezing, the person cannot breathe well, something is happening, there is a rash. This is an adverse drug reaction. What you do first is patient safety comes first, okay? Stabilize the patient, then report. Report to the attending physician, and the attending physician will write the adverse drug reaction form. This is the form. Let me show you the form. This is the form. Do you know where the form is at your station? No. Who knows? Alhamdulillah, ER does. Yes, you know why ER does? Because ER is so arranged, like they're so organized. They have this entire drawer for their forms only. Okay, please take ER as your role model. Know where your forms are. Okay? You don't use, you know where it is.
Because we are good.
Yes, you know where it is. You don't use it because there's no adverse drug reactions happening in this hospital again. So the clinical staff will report everything. They will document. Since this is not something as a near miss, adverse drug reactions have reached the patient. They have happened to the patient. So what you need to do is document in the patient file. Document the findings, documents the signs and symptoms which you think this is the thing I saw and I think it's an adverse drug reaction. That made you think it's an adverse drug reaction. Document the date and time where the physician was notified. Okay, you have to put that medico-legally for your safety. Okay, the physician will then fill the adverse drug reaction form and take all the process that needs to be done. The patient's file should also be flagged. Both paper and electronic files should be flagged for the allergy. So, say for example, diclofenac is a medicine that is usually used for patients to control their pain. Okay, you give it to a patient, and then this patient starts to stop breathing. They cannot breathe anymore. This patient is allergic to diclofenac. They should not be taking diclofenac anymore, and then their file, both files, electronic and paper files, should be flagged. I should see in the pharmacy when I'm dispensing their medications afterward, the part where it says no known allergies for all the patients, it should say this patient is allergic to diclofenac. Okay? So it should be flagged. And then the completed ADR should be submitted again to the pharmacy within 24 hours just to keep track of what's happening, because sometimes if it's a severe allergic reaction from different patients for the same medication, we have to report it to the MOH and the Saudi SFDA. Okay? Again, in case of this adverse drug reaction leading to a sentinel event, what do you have to do? OVR. Okay? Thank you, guys.